the ACEs Optimist Show with your host, Dr. Craig Morris.
Hi, everybody. Dr. Craig Morris here with ACEs Optimists. We are dedicated to the optimization of human potential in the clinic of life. I like to have people of unbelievable character, unbelievable experience, great professionals on my court in these podcasts. And I'm very honored to have a longtime friend and colleague, Dr. Gregory Yoshida, with us. He's a spine surgeon, a UCLA spine surgeon. And I think we go back, I was thinking about it, maybe more than 20 years. So welcome, Greg.
Well, thank you.
When I started working, I always tried to work with multidisciplinary in a multidisciplinary manner. And, when I first started in Torrance in 1982 in the LA area, there was only one orthopedist that would even accept a referral from a chiropractor. And so from there, I started working and finding people to collaborate with. And I worked with, initially worked with another spine surgeon who was a neurosurgeon for maybe for 5 years. And Dr. Sage, if you remember Donald Sage. And then he retired. And I go, what am I going to do now? Because I would go in and watch surgeries with him. And then I got lucky to share a patient with you. And we got a chance to get together, get to know each other. It was over 20 years ago. I just can't figure out how far back it was now.
It was, quite a long time ago, at least 20.
Yeah.
And I recall the patient, and you did a very fine job. So that was great.
Yeah. And so I like in these podcasts to try to get a better idea of a person's background. So I know we both were brought up in the South Bay. I was in Hawthorne and you were in Torrance. But what led you to medicine? What led you to orthopedics? What led you to spine surgery? What were the keys that kind of pushed you towards the excellence that I know you've developed and you've inspired now for decades?
Well, let's see. My parents stressed education. Neither of my parents had graduated from college when I was a child. My dad did go back. Both my parents went back. My dad started night school. I mean, he flunked out of University of Washington when he had the chance and then enlisted in the Army. And he then got a really good job because he is a bright guy. He just didn't know how to apply himself. His childhood he grew up basically on Skid Row in Seattle and no guidance, but he felt guilty that he had a good job without a degree. So he took night classes and then got into Cal State Dominguez Hills and got his bachelor's at, I think, 36, and went on and got his MBA. Then my mom went to El Camino College, got her A, and then went to Cal State Dominguez and got her bachelor's, I think, when my sister graduated from college. So,
Wow.
But it was kind of stress for education, and I was luckily a good student. And I was thinking, because I was fascinated initially when I got braces with orthodontistry. And so it kind of makes sense what I ended up in, but they explained to me how they took scans and how they worked their teeth and tried to make them straight. And, I thought that was fantastic. And so that was kind of what I was going to do. And then college applications came around, and it's very, very different when I applied. When I applied, you can only apply to one UC school. You couldn't apply to them all. And I wanted to go to Berkeley, and my mom really didn't want me to leave home. That's what it came down to. So I went to UCLA. I applied to USC because I'd been a longtime USC football fan, and I was in the band, and their band was really good. And I thought that was great. And then my mom's oldest brother, she was the oldest, and there were two brothers. The older one of the two went to Harvey Mudd. And so I applied there. And when it came down to it, the path I wanted to take to go to professional school and what I could economically achieve reasonably was UCLA. And so I did that. And I wasn't sure. I majored in chemistry because I didn't want to get but the summer between high school and college, I got accepted to a little program at Harbor UCLA Medical Center, where I am now still working. But those 10 high school students from the area, we worked in assigned to various labs with mentors, and we met with a physician preceptor. And we got exposed to aspects of medicine. And I had a wonderful mentor in my lab, immunology PhD, who encouraged me to go to medical school. And so he hooked me up with a lab at UCLA, then at Charles Drew Medical Center, where I continued to do research. I was on the forefront of some very big immunology research. I realized the precursor of basically labeling the T helper cells, or the T cells, the CD3 and CD4 dyes. My mentor was so well connected that he was able to get the dyes well early, and we just started that on mice. But I went to medical school. And I didn't know what I wanted to do there, but when you go through rotations, you end up gravitating to the people you are more like, or you seem to get along with when you do your clinical rotations. And I did like surgery, but out of all of them, orthopedic surgery really stuck out to me. It's I'm mechanically minded, and orthodontistry was my first love. Was this is wrong, this is right. That made it simple. But I was actually also drawn because at the time I was in medical school, the bronchoscope was used a lot for um, AIDS patients for diagnostics. And we had one of the co-inventors of it, and he was just a wonderful human being and was a great teacher. And it was a procedure. I felt I was procedure oriented, but in the end, I lucked out and matched in orthopedic surgery. And then during that time, I was lucky. I have good hands. I was told that multiple times. And it was just that technology was booming in spine surgery. And that makes it attractive because all these new things that think can advance the field. And so I decided on spine surgery. And that's how I ended up here today. And then just luckily along the way, during my training, I was offered jobs that I kept. And then along that, a teaching position. And it worked out great.
So you went to UC San Diego for medical school, right?
That is correct.
And then I remember then you returned back to Harbor UCLA for your orthopedic residency, was it?
Yes, they accepted me for my residency for orthopedic surgery, and I did my spine fellowship year at Rancho Los Amigos Medical Center in Downey. So it's both spine surgery as well as rehabilitation.
Yeah, because that is a famous rehabilitation location, but it had a huge spine fellowship program, very well known with a lot of leading authorities in the spine world that worked out of there and trained out of there and taught out of there.
Yes. And still a big one up at Stanford, who was my precursor. She's still very active.
Oh, really?
Yeah,
Wow.
doctor. Yeah, so she's a very big contributor to the field. Also, one of my spine attendings when I was a resident, she was a volunteer attending. She also worked a lot at Rancho, and she was an inspiration. She has since retired.
It's fantastic. So we got together, we got to know each other 20 plus years ago. And I think for me, it's been a wonderful working relationship that turned into a friendship over the years. And for me, it always felt like the more I could team together with other specialists, the better it was for my patients. But I'm not sure if there was anything that I brought that was a little bit different than the other chiropractors you had worked with. But I really appreciated the teamwork that we found. I was in many surgeries with you, and I consider you. Well, after observing many spine surgeons, I found there were just a rare few that they were kind of like fish in water when in the operating room, and it was so easy for them. And you definitely were at the top of that list. And so for me, it was always an opportunity to go in the operating room and learn. It was continuing education for me. But from your perspective, I think our work relationship was a little unique.
Well, it was a very good. You are one of a handful of chiropractors that I worked very closely with because they understood what they should and shouldn't do,
Yeah.
what red flags were. Some people will push through with, I mean, it must be their training, but in unfortunately misdiagnosing or mistreating certain diagnoses that should be seeing a surgeon sooner than later. You never did that. You always had pertinent questions. And then if I had a patient that I had problems, which was more neuromuscular re-education, which is what you were very good at compared to many other chiropractors, you were, I'll be honest, I gave you a lot of my most difficult patients, and you would help most of them, which was a change, and that was nice. And you had a way of getting through to the patients too, which was different. Like some therapists, I mean, they do their things, but you had to get through to the patient to participate in their care. And you and a few others were very good at that. And that's why I think it was a relationship of mutual respect and admiration, as well as doing what is best for the patient, which was number one.
Right. I have another colleague who's a surgeon, orthopedist, that he talked about, referring out to chiropractors, and his number one instruction was no blowback, which is pretty concise, but it's like, don't give me complications. I'll send you this patient. I want you to help them, but definitely don't cause problems.
Right. And yeah, I mean, that's also a chiropractor understanding what they can and can't do, much as I, as a surgeon, have to know what I can or can affect a change in a patient. There's some patients that they may have pain. Unfortunately, though, there is nothing surgical, and some doctors will chase that in that, and some patients will improve. We don't know why, but generally speaking, if the success percentage is low, I don't want to do harm to the other majority to get those few successes. I would rather go through other means, which I found success with you and other modalities if we work as a team. I think that's what's best. I mean, surgery is a big deal.
Well, I remember we've had a lot of time, social time together, going to dinner and having really nice times over the years. A lot of times we would end up talking a little bit about some of our frustrations with our colleagues, mutual colleagues. And I always found that what you just explained very nicely, you were more conservative when it came to surgery. In other words, if you were confident you could help them, you would, but there were quite a few others who were more, what I would say, aggressive in the cases they would accept, and sometimes even the procedures they would perform. And I think we both found you taught me about that from the side of the spine surgeon, and I think I brought some of my insights for concerns and what to look for actually with also with other chiropractors.
Oh, yes, that helped immensely. I mean, you always, and you do too, you kind of have a feeling, but it's nice to kind of have it illustrated out based in facts. Um, you know, I was very lucky. Yeah, you as well as other like physical therapy places, they would tell me my patients tended to do better than other doctors. Well, you have to pick the right patient that you can help. Then you tend to get better results. Um, and yeah, I'm thankful that I was able to help people. You know, uh, it is frustrating to patients where I am unable to help. And those are sometimes desperate patients that will sign up for anything. They're a vulnerable population, and uh, it's you have as a human being, as an ethical human being, I have to resist that urge to be able to needle them into something that might or might not work. I want to do something that I'm very sure is going to help. So and everyone approaches their practice differently, but that's how I approach mine.
Well, I always knew when I was referring patients to you that they were going to get sound care, but they were not going to get pushed into anything or manipulated. That you were going to be very diligent in the assessment and not necessarily oversell. It's very easy in healthcare for people to get caught up into the sales side of it, I think, and to, again, say, I think this, especially as you see the more desperate patients come in, and then instead to have the wherewithal the character to be able to say, I know you want this, but I don't feel that you're going to be in the long term better for this. And so I can't do that. And I know that you turned away a lot of patients. Even we talked about, and I'd even seen some that had surgeries from other spine surgeons that ended up coming to me, and they didn't go well. And so for me, it was easy. For me, at the time, it was a reflexive action. Go see Dr. Yoshida. If I had a red flag case, go see Dr. Yoshida. If I had concerns, even if I had concerns that were even maybe not necessarily specifically orthopedic surgery, but that I wanted a second opinion if this needed any kind of other referral, or because we could have complications with depressions and other conditions, and psychiatrists. But at the same time, with your years of experience, your decades of experience also, and then it was a second. I knew I had somebody who I could trust, who would just tell me what to do or what they recommended. And sometimes they'd have injuries or other conditions that were in orthopedics. People sometimes forget that a spine surgeon did their residency in orthopedics. They're still an orthopedic surgeon and done plenty of surgeries outside of the spine. And so, I had a saying I've said in my courses, that my job when the patient comes in is to keep them out of surgery, but then to thank God for the surgeon when I fail and they need the surgery. So I'm doing everything I can to avoid sending them, but I couldn't always do that. That's not, and then I say, thank God I've got Greg up there because you ended up being upstairs or downstairs from me rather, in the same, where you ended up in the same building.
Right. And the same thing for me. I had patients that you search, you want to run all the diagnostic tests, and there was nothing that I could physically do with my hands to improve them. And then, so thank God you were upstairs, because that's something that they needed a different approach to the issue. It's unfortunately surgery was not going to improve their pain, but I had to find something. And like I said, generally speaking, you had a very good success rate.
I remember one patient. He was an elderly gentleman, and he was a retired police officer, actually, and a retired sheriff. And he had terrible spinal stenosis with some terrible leg pain. And you referred him over to me. And I still remember he was a very enthusiastic, wonderful communicator, and just delightful person. But he said, my leg was killing me. I couldn't stand the pain. He said, and if I went over to see Dr. Yoshida, and if he was said, I'm going to have to cut off your leg, he says, I would have rolled my pant leg right up and done it right then. I remembered very well. And he said, instead, no, I think we need to try you with Dr. Morris. So go see him first, and let's see if that helps you. And he responded very well to that spinal stenosis. But I always remember him because he absolutely adored you and fully trusted you, as he should and should have. And he responded well at the same time. And I saw him a few times over the years, but it was the types of wonderful cases we had a chance to help each other's patients. And
Yeah.
also, and go ahead.
No, he was a tough one because, generally spinal stenosis responds well to surgery, but he had other issues that would have made the surgery so tremendously large, then the cure is kind of worse than disease. So I was very grateful that you're able to help him, because the option that was left, he said if I cut off his leg, but that's a simpler surgery. I told him what you have to have would be a humongous thing. And so we agreed, and he went into it wholeheartedly, and it helped. And that's the whole idea. Sometimes there is something to do, but then the risk benefit ratio doesn't pan out. So, yeah. So same thing, patients that the surgery was so large, it has its own downside, versus patients that don't have something that can help. I think that's where you came in wonderfully for me and my patients, for sure.
Yeah, well, I feel very fortunate to have been part of this partnership. And I've got a couple of other areas I'm really curious about now that you're working full-time at Harbor UCLA, and teaching with the orthopedic residents there. First is, Is there a difference that you see in today's residents as they're coming in compared to 10 or 15 years ago? I mean, cultures change,
Mhm.
change, and how do you, if you notice any, what differences or to your approach to instruction?
Well, it's a cultural change to be, I think it's just how the environment these people, the new generations are raised in. Also, the differences are more pronounced between subspecialties. I mean, before all physicians worked, and I'll be honest, I think we worked too hard. We let a lot of other stuff pass. Then they passed hours restrictions. Then um, it's less financially rewarding. I mean, you have to, I hate saying that, but that does influence people how hard they work. If you can make a lot more money working a lot harder, they will. If you don't make that much more working a lot harder, or you can make good money working really more reasonable hours, I would do that. Those are options today, which is very good. It's maybe tipping the other way. Medicine is turning more into shift work. And the laws were passed to try and prevent medical errors. Unfortunately, the medical error rate is about the same because handing off a patient to a doctor who doesn't know as much as about it has an equal chance of making a bad decision as a tired doctor who knows a lot about a patient. It's still a very small percentage. I mean, these are regulations that are being passed for the exceptions. Unfortunately, though, in medicine, the exceptions lead to very bad consequences. So I can see the intent of the law. In the end, though, if we look at it, it has just replaced one issue with another, just as many things happen. But the new generation, orthopedic surgeons, residents, based compared to their cohorts in most other specialties, still want to work hard. But they do value their time a little more than I did as a resident. And I, I'm going to say it's a good balance. Some residents tend to lean too far, but overall, we are lucky. Our residents are still more invested than interns we see from other services. And it's funny when I hear our residents complaining about other specialties, how they don't want to work. But in general, the strive to overwork, I will put it that way, is not there anymore in medicine. Um, and a lot of doctors just, even in certain communities, just treat it more as a business and a 9 to 5 job. Um, but there are still, thank God, there are still exceptions, who do a concierge practice, get to know their 200 or 250 patients they take on. Um, I know many subspecialists who are very proud. I had a huge surgery yesterday, and it was a vascular surgeon who did the approach for us to get to the spine in the front. And he had been in private practice, and he didn't like some of the ethical quandaries that some of his partners were putting him in. They were maybe possibly making some decision based on money. Um, and then so he became the county, but then he also has the issue with who wants to work, but he was fully invested in the case. And I told him he did a great job and we get along. So we're going to have a long partnership. But once again, you find like-minded people
Right.
and you
That's
keep doing good work. That's what it's about.
yes. Well, we kind of worked, I think, almost in like a golden age of spine surgery because so many changes occurred. And I started a few years before you, but
Mhm.
still big changes in our imaging and the quality of our imaging and the standards, and also the surgical procedures and approaches and new technologies. And now I've been away now for several years since I sold my clinic there in Torrance near you. And I'm curious if you could give us a brief idea of the kind of changes that have occurred maybe over the past 10 or 15 years that have changed the standards or changes the procedures or changed the technologies as you see them.
Well, I mean, I think we keep all of medicine, we reinvent the wheel. because we find something good for one indication and we want it to work. So we apply it more broadly. Then it gets a bad rap. Then we come back and say, oh, it's good for this thing. In spine surgery, I think the biggest advancements have been in how the instrumentation, that is the tools we use to perform the surgery. They've gotten better. So the surgeries are more efficient, less fuss factor. We do have more technology involved, but be honest, some spine surgeons are too dependent on that technology. They still need to know how to do it the old-fashioned way. I mean, I've seen cases in the hospital I work at where there's a machine we call navigation that helps you put screws in safely, but it can be used incorrectly, and we've had to take care of that from other people. But those cases, the machine broke. The surgeons actually aborted the surgery. Whereas my service, we can still do it because we know how to do it. And I have a new wonderful junior attending just out of fellowship who has the same thought process I am. I'm just grateful he's there because, you know, I am not going to be there forever. I mean, I have maybe 3 to 5 years left. And it just because I don't want to be there when they tell me to leave. I want to go out, you know, like Sandy Koufax, essentially. Still
on your volition.
I'm still on top of my game, but maybe I can't do it. But this guy, same thing. We had a case, the machine broke down. This was last night, and we did it the old-fashioned way. And he actually, we were sending some, you know, messages, and he just wants to know what would neurosurgery done. And pretty much everyone knows the other service. It's just there's a couple surgeons that are very dependent on it. They would have canceled the case, and that's safe for the patient, other than needing another anesthesia. So the problem is there is in all fields of medicine, there's a lot of technology, but I think the surgeons, the younger generation, because they've grown up with technology, and believe me, they are way more savvy than I am in that. But they can get too dependent. And just like if something breaks down, you still have to know how to do it analog. And I think that's being lost a little bit in medicine, but I'm trying to make sure that doesn't happen on how I teach.
Fantastic. I know there's one procedure that I was always intrigued that you did that I don't think too many spine guys did, which was your laminoplasty procedures. Do you still perform those?
Yeah, we just did did 2 with my current chief resident who was actually going into spine surgery. And for the right patient, that is the best procedure. But once again, it's not for every patient, and done incorrectly, it's not good. I know some people that I trained, and where they trained for spine surgery, I mean, they were a resident with me and did them with me, but they won't do that surgery because the people they trained with didn't learn it. And it's a very, once again, it's a niche surgery, but for the right patient, I still feel it's the best procedure. And I call it's a more elegant surgery. And yeah, we've done all, we just did 3 in this last block. So yes, it's for the right diagnosis, that is actually the procedure that should be done. So, but there is an alternate procedure. It's just, I think the laminoplasty still preserves motion, so I prefer that over the alternate procedure if you can.
And just for the audience to understand, this is a procedure where you have a spinal stenosis, a cervical spinal stenosis. Is it always cervical, isn't it?
They can do it in the lumbar, but the benefits of that haven't been proven as much, and a laminectomy in lumbar spine is less detrimental. You can technically do a laminectomy alone over many levels in lumbar spine with a lower risk of what we call instability or the bones getting loose. In the cervical spine, depending on what study you read, if you do a multi-level laminectomy, the chance of post-surgery instability and deformity of the neck is anywhere from 20, and I've seen some studies say up to 40%. So if you have to do a decompression, that is to make room for the spinal cord, the 2 procedures are either you do a laminectomy, that's removing the bone, but you'd have to fuse it at the same time to prevent the collapse, or the laminoplasty, because the laminoplasty keeps the lamina intact, just moves them to make the canal or the spinal cord bigger. Instability is very rare. So I like to preserve the motion. So
And you add extra bone taking from the spinous process, right? And then you fill that in. Is that what
No, that's where technology, we now have wonderful little plates.
Oh,
And they're very well designed, and it you can customize the size of your opening, and you're not dependent on what the patient's bone is like. So that's another advancement that's made since I had finished my fellowship. We had to use the bone. You're correct. There's spinous process, but now the
yeah.
plates are very well designed, and they're multiple on the market, and they're all very good, and it's what's used.
So now it's a little simpler and quicker surgery because
Yeah,
you don't have to harvest bone from the spinous process.
correct.
Very interesting. Uh, and what about scoliosis? Have there been changes? I remember observing a scoliosis surgery, a modified Zilke procedure about 30 years ago, but I've never observed another scoliosis surgery. And have there been changes or updates or improvements in the modifications?
Well, yes. If you're talking about adolescent idiopathic scoliosis, that's the scoliosis of
I
school
am. Yeah,
children.
right.
The Zilke procedure you saw was where we'd go in the front of the spine. And the idea of that was to save what we call levels. Because if you go in the front, you can get a better correction and you don't have to go as many vertebra. So you don't freeze up as many vertebra in a young patient. Are the advancements of our technology in our screws and the materials, the biomaterials, the metals we use, we can achieve the same sort of correction from the back only. So we avoid going in the front. So it is very rare in idiopathic scoliosis now for anyone to go in the front. It can be all done with the back, through the back with the new technology, the instrumentation that's available. We did 3 this block too. It's been a very busy past few months. Um, and it's amazing what we can do with the new technology. Way better than what I could do when I thought we had really good x-rays. I think we could have made them even better with the technology. It's just the metal wasn't there, the design for the screws, the rods, the new alloys are stronger. And we're understanding the overall alignment. We're getting more specific measurements we can do. Before it was research, and now that research has been able to coalesce together to get good numbers that we can follow as better guidelines. They're still not perfect. I mean, people will argue, but with the new parameters, we can ensure that if we're going to do a surgery, it has a better chance of less effect in the future and lasting longer.
That's interesting. And last question, if what advice could you give to young clinicians, chiropractors, physical therapists, whatever, that are looking to establish relationships with orthopedic surgeons, spine surgeons, so that they can be able to refer their patients and to be able to communicate and to team together?
Well, one is you, you need intellectual curiosity. I mean, it, they have to be able to look at what they're doing and ask another professional, um, how am I doing it? What do you see that I'm doing? How does it help? How do you like me to approach, let's say, for a surgeon post-op? Tell me what the surgery is. I mean, if they can get interested in what is being done, they can maybe help tailor the rehab, or the surgeon or the chiropractor can help them tailor what to be done for each individual patient. Um, but nothing replaces being curious and wanting to work hard. You can be curious, but if you don't want to pursue it, that doesn't do any good. If you just want to work hard but don't want to change or see what you're doing, how it affects people, what we call outcome-based, learning, then that doesn't help either. It takes a little bit of both. And that needs a viewpoint of what can I do to where I can help my patient more. You know,
Yeah.
it's not yes, I can better myself, but the goal of bettering myself is to be a better use to who I serve and who I want to help. And that's an attitude that, it has to be not egocentric. And I think that's really important. But I think most people go into healthcare, that's the reason we go in, majority of us.
I'd like to think so.
Yeah, me too.
I know that I would, um, when I would be the one typically to reach out because I had a problem. I had a patient that needed something, and I didn't want to just open up a phone book when they used to have them. And I would try to always be trying to, I would like speak with my patients, speak with my colleagues to find out, the best guys in the area. And then I would call them and take the time to introduce myself, like I did with you.
Yeah.
And, invite them to lunch or to dinner. We went to lunch that first time. And I remember my first time because I looked at you and you looked so young. So I had a joke in the back of my mind thinking, I wonder if his patients asked for him to be accompanied by an adult or by a parent, because you looked so young back when you got into practice. I don't remember how old you were, but I think you looked 10 years younger back then than
No,
you.
I was 31 when I started my practice, but I'll tell you, that first decade, I lost a few patients because they thought I was too young to be their surgeon. And that's the truth. They just told me I just thought you're too young, and they went to someone else who was actually just a year older than I was, but it's all right.
Yeah, you had
Yeah,
that was
patient has to be comfortable with their doctor, and I said, that's fine.
that's right. Although it was a double-edged sword, especially as we get older, the idea of looking younger, and you still do, is still now a more and more positive thing. But I think when it comes to being a young clinician and wanting to grow, the first thing you think is, well, I want to be busier. I want to grow my practice, and that's understandable, but that's not the approach. The approach is, how can I be of service, and how can I find out, how can I be of service to my patients, and how can I be of service to these local specialists? And the way to do that, I think, is to find out their problem cases. We spoke about it earlier. There's cases where you say, you know what, this is not an orthopedic surgery case. But then if you don't have somebody to refer them to, then instead you're gonna keep coming back, and you're gonna be saying, well, I can extend whatever, I can give you more medication or this, but it's not a surgical case, so you don't have options for them. But if you have people that can come and explain what they can do, and then there's no blowback when you send them, then all of a sudden now you become a value to those local specialists, because they can send you their problem patients.
Well, yes. And the other thing too is when you do that and a patient does improve because you knew you couldn't do anything, or they send you a problem patient and yes, you want to get busy, but if you do quality work and take an invested interest in your patient's well-being and send them to who you feel will serve them best, even that in itself will then return to you by making your practice busier because people talk. Like I said, a lot of my referrals came from therapists, chiropractors, and the nurses in the hospital because they saw the difference. And it takes a while. I mean, I didn't go crazy. I'm not the greatest schmoozer, but you let your work speak for itself. And that I can't say enough about that. And really have an invested interest in how your patients do. Nothing replaces that.
Amen. Well, I'd like to thank you for joining us today, Greg. I learned so much from you over the years. I learned on cases that I wasn't quite sure, cases I needed a second opinion, cases that patients came in severe pain with acute radiculopathies, where you were available. You take them at the last minute. You take my surgical cases. You invited me into the operating room so I could observe the surgeries. And you know me, I was the curious guy. So I was asking questions, and you were always so wonderfully kind and accommodating to answer my questions. And also, it meant quite a lot to my patients for me to be there to say goodnight to them right before they went into the general. and to tell them that they were in the best hands, because I knew they were. And I think they saw that also we had a wonderful camaraderie and partnership and teamwork. So they knew that they had their doctors were in communication and teaming together for their benefit. And I can't overemphasize the importance of what that can mean, especially to the more complex cases where they don't know where to go, they don't know what to do, and very often they go to two doctors, they get two different opinions. So that even makes it more confusing. So in a time where, I think it's more important now to find this networking and this camaraderie and communication more so than it's ever been in these challenging times.
Oh yeah, it was once again, it was a pleasure working with you. I learned a lot too. I mean, it goes both ways. So I knew who to turn to with certain questions. So it was very mutual, and it was a good run.
Absolutely. We are both very fortunate. Thank you
Yeah,
again for joining me, and we'll see you next time, everybody, on
my pleasure.
Optimus.
Bye,
Bye.
guys.
Thanks for tuning in to this episode of the Aces Optimus Show. Catch you on the next one.